開特會啦，咁啱啱我哋夠。
All right, we have attained the quorum. It is time to make a start. This is the panel on health services. Shall we invite the administration in? Let's save a bit of time. Shall we invite the administration in, please? Agenda item 1. We have all the information papers on the agenda. If you see the need for any discussion, please give me a shout. If not, shall we move on to agenda item 2? There are 2 items. The first one is enhancement of medical fee waiver system of the Hospital Authority and Hong Kong Strategy and Action Plan on antimicrobial resistance. Bit of a mouthful there. There are 2 items there. There's 2 members have any particular items to raise. In connection with the rare disease, I understand that some information is being put together which will be made available to members. I think if a visit has to be made, this will happen by the end of this year, early next year. Chairman, there is an item which we should have a go at, which has been on the list for a long time, and that's the dental service. Chairman, the PAC would not single this out for hearing, and I think the HSP should follow up on this. Now, this is an issue picked up by the Director of Audit, and this is not controversial. I think we can fit it into the agenda. Yes, this is about the Director of Audit's report. Mr. Raymond Chan has submitted a paper to discuss A's. Now, Mr. Chan is not here today. Chairman, it should be fine. We can have 4 items on the agenda. It should be fine as long as you're prepared to stay. We can have the meeting till 8. I've been here for 2 years. On this panel. Now, you must be here. You have to be here if you move an item. Dr. Fernando Cheung, Chairman, the dental service is an important one. Other than the Director of Audit report, we have discussion on the extension of dental care for the intellectually impaired. That the administration has got some undertaking there. I think the new administration should be alerted to this to make sure that they are sufficiently concerned about it. Now, you said that we should put it here. We can come back for this in October. Certainly we can have a go at this in October. You'd like to have a go at this in July, don't you? Yes, I saw another hand there somewhere. Mr. or Dr. Pierre Chen. All right then. The Director of Audit investigated the dental service. We can have a look at this. Now we can have 3 items. Do we have an extended meeting? Which one should we take first, the administration one or the dental service one? We can have a look at this later on. Anything else for the next meeting? If not, then we go straight to item number 3. That's the mechanism for handling medical incidents in public and private sector hospitals. Under Secretary, Chairman will have a look at the medical incidents handling mechanism for public and private hospitals. In 2007, the HA introduced the Centennial Event Policy, and in 2010, some improvements and some updating have been made, and they introduced the sentinel and serious untoward event policy. And this is to require all hospitals and all clusters for 9 sentinel events and 2 serious untoward events within a 24-hour period. Notify the head office of the hospital authority through the advanced incident reporting system. For each reported incident, the HA will appoint a root cause analysis panel to identify the possible root causes and to identify risks and recommend improvement measures. In May this year, a task force has been set up on the sentinel and serious untoward incident and see how the existing system can be improved. By July this year, the report will be submitted to the full board of the hospital authority. For the private sector, since 2007, all private hospitals are required to submit all the sentinel events within 24 hours, and since 2015 we have aligned the practice for public and private hospitals in relation to the reporting of sentinel and serious untoward events. For private hospitals, again, they have to conduct an RCA investigation and introduce risk mitigation measures to prevent a repeat of the incidents. The hospitals have to submit within 4 weeks an investigation report to the Department of Health. The administration and DH will monitor the reporting procedures and the statistics and make announcements to the members of the public. Thanks very much. There are 4 members who would like to put questions. Dr. Hon CHAN Chi-chuen, Mr. Yu Si-wing, Mr. Poon Siu-ping, and Dr. Pierre Chen, and also Dr. Fernando Zhang. 3 minutes, please. Dr. Kwok, please. Chairman, thank you. I meant to talk about the major problems of the hospital authority, but the directors are not here. No, the Ms. Tang Kwei-si's case, which we do remember, it could have been handled differently, where the whole of Hong Kong is looking for a liver for her. In fact, in April, Ms. Tang went to UCH, and on 5th of April, she went to Queen Mary Hospital. If it wasn't for her daughter's inquiry at UCH, nobody could have known about the whole thing. And she was notified about it a couple of days later. And none of the hospitals followed the guidelines. Now, this is a case, number 4, a case of medication error resulting in major permanent loss of function or death. This is not a case just for UCH. Members probably remember that the 10 years ago, these guidelines were put together by the executive, but they didn't follow the guidelines at UCH and also at QM Hospital. They don't even follow the guidelines that are put in place. They're not as good as the paper that is written on. So everybody is losing confidence. The senior executives do not have to see the patients, but the hospital authority has been criticized for covering up the whole thing. The senior echelon has covered up the whole thing, and everybody is really dragged into it. Now, for the senior echelon, they didn't take the reporting sufficiently seriously. Under Secretary, Dr. Kwok mentioned a specific case, like the NUCH incident. Obviously, we talked about a reporting mechanism for the UCH incident or any other incident for that matter. There is an RCA that would look at all the incidents, all the details. But Dr. Kwok, I'm talking about the reporting procedure. Why is it that it's taken them such a long time to make a report? Under Secretary. Now, there are problems with regard to certain hospitals for which they will look at the root causes. That this system has been in place for 10 years, and they have an independent panel that will look at the mechanism to see what we can do going forward. Dr. Kwok, Chairman, let me just finish. You've got a second round, Dr. Kwok. Now you've put a question about who should be held responsible. Right? Will you take the question, please? Under Secretary, who should be held responsible? There are two questions there, in fact. Well, these are hypothetical questions. In terms of the reporting time, I fully appreciate that there are certain comments from some quarters. As I said, in early July, we should have the report available. Until we have that report, it would be hard for us to come to any judgment. Mr. Yu Xi-wing, we don't really want to see any medical incidents. But there are so many patients every year. Out of 1 million cases, we have 1 case or more of medical incidents. Medical incidents is something that one too many. Of course, we cannot avoid medical blunders altogether. Maybe an accreditation system for the hospitals would be good enough to see whether the hospitals are measuring up to international standards. It would be easier for us to ascertain whether the blunders occurred because of the management problems in hospitals. From the administration's reply, you have commissioned Australia to come up with an accreditation protocol for hospitals in Hong Kong. Now, this is really something good for public and private hospitals. If there is an accreditation system, then it would be really good because there are measures to monitor the risks, and there would be a protocol to follow. When incidents occur, then we can assess whether it is caused by human error or whether it is caused by some inevitable issues. My question for the administration is this. Will the administration make it mandatory for all hospitals, public and private, to implement this? From the information, the hospitals that accept the accreditation system stands at 30 or 70% of the public hospitals, but for private hospitals, all of them indicated some intention to join. Now, if this is something good, will you make it compulsory for them to be brought into the system so that we don't have to surmise what actually happened, and we don't have to pick someone to share the burden or the blame? All right. Thanks very much, Mr. Yu. Mr. Yu is talking about the accreditation. Now, accreditation, together with risk management and procedures. Under Secretary, For accreditation, the hospital authority has got a timetable, and there is a pilot scheme that is going on. Other than public hospitals, private hospitals are also involved. Perhaps Dr. Liu can supplement. Chairman, members, the HA will conduct accreditation on all hospitals in batches, and this would include risk management and all the 9 sentinel events and 2 serious untoward events will also be incorporated into the accreditation system. Surveyors will have a look at these as well. Now, if the sentinel, if the pilot scheme is good enough, will you be implementing this in full scale, and everybody would have something to go by? Yes, indeed, Chairman, we would cover all public hospitals in the system. Mr. Poon? Chairman, thank you. Today we are discussing the mechanism for handling medical incidents in public and private hospitals. There is a paper on this. The Undersecretary said that the medical incidents have to be reported within 24 hours. For public hospitals, they have to be reported to the head office. For private hospitals, to the DH. Now, my question is, have we seen any cases where reporting was made out of time, and also the penalty if they failed to make a report, or if they made a report out of time? What is the penalty like in the past?
You also mentioned that after reporting, a root cause inquiry panel will be established. As far as I understand, hospital authority representatives will be sitting on the panel, as well as independent clinicians. Is it that there is a certain ratio between different categories of members, and if so, what is the ratio? Of course, setting up the root cause inquiry panel is to get to the bottom of the cases and find an inquiry and find the cause of the incident, and to protect the patients in due course. So, in accordance with the number of sentinel causes and SU events, there are certain categories which point to certain structure remaining within the body of the patients after surgery and other procedures, as well as patient suicide. And it seems that every year, on average, there are a dozen cases. Now, it seems that you have already identified the causes. Why is it that the number of cases have not come down? Is it because of lack of manpower? Or do you have any other information for us in this regard? So you want to know whether there is any overdue reporting, and if so, whether there is any penalty. Of course, if there are sentinel events or SU events, the details involved in the cases necessarily are rather complicated, and that's why there is a certain amount of verification work that has to be done. And as for the details, I defer to my colleague, Dr. Lau Siwa. Now, as for the root cause inquiry panel, he will also give you the details concerning its formation. Now, concerning the root cause analysis panel, we do not have a specific ratio concerning different categories of members, but there are certain guiding principles. The medical team that has been involved in the case will not be represented on the panel, and we are going to make use of the hospital cluster system to engage experts that are not involved in the case to look into the cause. And also, if necessary, academics as well as universities, as well as outside experts will also be invited to come along. And the guiding principle is really not about penalizing the person that is responsible for the incident, but to find out what caused the incident and how to prevent it from happening again. So the key word is prevention of future events from recurring. And when we analyze the report of the panel, our focus is to look at the recommendations concerning manpower, concerning equipment, concerning system and work procedures, and so on and so forth. And so we are going to study the recommendations and the findings in depth, and if necessary, we are going to communicate further with the root cause analysis panel, and if necessary, improvement measures will be put into place. As for reporting, as for the timing for the reporting, at present, we have a very simple system. When an incident occurs, our frontliners will go through the medical incident reporting system, and any incidents can be reported through this system to the management, so that the management can offer support or offer a response. And after the air system is activated for reporting, a designated officer will be named in order to carry out assessment to see whether it falls under the category of sentinel events or SU events, and within 24 hours the headquarters will have to be notified. The bottom line is that we can immediately step in and we can immediately look after the best we can the interests of the patients, and if necessary to also set up the root cause analysis panel as soon as possible. During the past decade, close to 20% of the cases have failed the 24-hour deadline, and mainly because such incidents usually involved very complicated procedures, and there are complex causes leading to their happening. And that is why the management will have to take some time in order to establish the cause of events and so on and so forth before determining whether it's a sentinel event or SU event or otherwise. And that is why in terms of timing of reporting, the deadline has been exceeded by these cases. And in certain cases, holidays have also intervened in the course of reporting. As a result, reporting has been delayed somewhat. Regarding medical intervention and surgery, and thereafter certain stuff has been left in the bodies of patients, I'm going to defer to Dr. Sin to give you an analysis as to what has been the nature of these cases during the past few years. Dr. Sin. Concerning materials left in patients after surgery and after medical intervention, the number of cases on average has been 10. Now, if we're talking about big objects being left in the bodies of patients, the occurrence is really very rare. Usually what happens is that very, very small size items or objects being left in the patients. We're talking about stuff that is barely visible. Usually what happens is that a patient is released, and when he comes back for x-ray, and it's then only discovered that a very small and minute object is being left in his body. And then we will immediately try to establish whether that particular object is actually connected to a previous operation. And if it is indeed discovered that the patient has undergone a certain operation, then there is a greater likelihood that it is being connected to an operation. Member has asked 3 questions. You say that there is a mechanism, and Dr. Lau said that there was indeed certain cases where reporting was being overdue. And he also asked whether there is penalty. Now, it seems that you haven't answered that. Now, so many risks have already occurred, and we just want to know whether those risks have to do with manpower shortage and so on and so forth. It's been 8 minutes already, and it seems that no questions have been answered. I don't think members need to know too much about the technicalities, because you are technocrats. You should know the details, not us. If we're talking about colleagues have been found lacking in terms of professional performance and output, Dr. Liu, please cut to the chase. He was asking whether anybody has been penalized. We're not asking whether for professionals what will be the penalty, and for administrators what will be the penalty, and so on and so forth. It's been 10 minutes already. You're still not hitting the screw on his nail, or hitting the nail on his head. So we just want to know whether anybody has indeed been penalized. Now, if there have been none, then just tell us. And then we want to know whether it has anything to do with manpower shortage or what. Because I can tell that Mr. Poon wants to know the answers to these two questions, and it seems that you have yet to answer any one of them. So, Bureau Secretary, indeed, we heard the questions. Of course, the exact figures will have to be tendered by the hospital authority if available, but in the main, if there is overdue in reporting of incidents, and also what have been the causes of such overdue in reporting of incidents, I think hospital authority will need to look into those. And whether medical incidents have to do with manpower shortage or manpower arrangements, I think the root cause analysis panel have already come up with their own findings. And I think hospital authority can tender the information to you. Right? In that case, will you please tender the information to Mr. Poon? Mr. Chen, I don't think we need to set up an RCA panel, because we are obviously not happy about what happens afterwards. It seems that the root cause analysis exercise is really futile because it is now down to the public as well as to the media to come up with a final judgment. Now, as a doctor, the bottom line, of course, is that we have to be answerable to the patients. Of course, we don't want to see patients being victimized by professional misconduct or any lack of performance on the part of medical practitioners. If you look at point number 21 of paper 21, the hospital authority says that many of the cases as well as problems are caused by system, not caused by personnel. So I think at least it is doing some justice to the doctors. Annex 2. Now let's look at Annex 2. Now, sentinel cases and the numbers. So my first question is for the hospital authority. I'd like to know whether whether all of these categories are medical mishaps or human errors. If not, then which of these categories are not human errors? I don't think you can generalize this. Because a colleague already asked, it seems that every year out of over 1 million patients, about a dozen patients have taken their lives. And so he was asking whether it is because of medical mishaps or because of lack of manpower leading to these patients' suicides. I'd like to know whether these dozen cases actually were cases related to the hospital authority or related to manpower situation at the hospital authority. Of course, we have to look at our manpower support and also manpower system and arrangements. Now, because we're pressed for time, okay, we can move on. Now, Annex 4, about private sector. Some of my colleagues have already pointed this out. SE7, SU1, and 2. Now, for 3 years, the number is 0. And we have heard from the news that there have been cases that should have been reported but have not been. So my question is for the Health Department. Why is it that for some of these categories, the number is 0? And also, it's been discovered that some of the cases have not been reported when they should have been. And it seems that you have done nothing against those. Now, the situation is actually rather obvious. And so what are you going to do in order to rectify that situation? Now, regarding the Sentinel cases and the relevant arrangements, they came into place in June 2015. And in 2015, they have not tendered information to us, and in 2016, 7 cases. And some members have already asked what have been the cases that have failed or have been failed to be notified to us within 24 hours. Actually, the number is 24. And what happens is that once we discover those cases, we're going to write a letter of reminder to the relevant authority, and we'll look into whether they are having a shortfall of manpower or shortfall of equipment. And so we're really worried that they fail to report cases. And so what we do is that we would look at the hospitals and we look at the cases that they have reported and to see whether there have been any missing cases. And also some of the cases will be given direct to the health department. And in other cases, the hospital authority will give us a summary of the cases. And so we'll look into those lists to see whether there have been any missed cases. And indeed, in the past, we have discovered that some of the cases have been missed. And we'll have follow-up on those.
Any penalty in SE7 maternal death, not just public hospitals. In private hospitals, the number cannot be 0. I know that there have been omissions. Like Chairman said, any penalties there that have been meted out. Under the existing ordinance, there is not much in the way of penalty, so we can only issue warning letters. The government has reviewed the ordinance, and if there are omissions, it is likely that we can suspend the service, or we can suspend or revoke the license. Now, for labor and delivery, if there is maternal death, it has to be reported to us. I think the hospital authority has already said that the purpose of filing a report is for us to learn a lesson and to mitigate the risk. And there may be reasons like it was caused by pre-existing illnesses. And these are the sentinel events and serious untoward events. That the figure may not be consistent with the pregnant women dying in the course of labor. Dr. Fernando Zhang, we support this reporting system because this is in line with international practice. What we are concerned about is that through the reporting of cases, you would conduct an analysis, and in your recent report, it shows that since 2016 there have been 85 patients who committed suicide, and this is half of the number of events reported, and this is about half of the cases. Now, for those committing suicide, half of them have already left hospital. That's on home leave. I'm not sure whether there is a better term for that. They are technically inpatients, although they're allowed to leave the hospital briefly. Having conducted the analysis and having reviewed the home leave, should there be any particular procedures to reduce the risks? I think the report is completely silent on this. Maybe I haven't got sufficient time. I think after the cases have been reported, it is important for you to make improvements. Recently, we have the Ms. Tang Kui-Si's case. A number of members already touched on this. There are problems with the reporting time. The reporting was made about 10 days or so late. Now you said you have to investigate the case. For this, the reporting system is not really a matter for judgment. It is important for cases to be reported in the first instance. It seems that you failed to achieve what you set out to do. Can you tell us, there are 20% that could not be reported within 24 hours. Of course, members mentioned some omissions. This 24-hour reporting is important. Is there anything that can be done to minimize the late reporting? People get the impression that unless people pursue the matter, the issue would not be reported. With the reporting system, I'm sure that you would like to have higher degree of transparency. Can you address the question there, please? Thanks very much, Mr. or Dr. Zhang. Like Dr. Liu Xiaohei said a moment ago, I think he can supplement more later. There are two levels here. The first one is on the front line. If there are any incidents, then there is this reporting system for them to file a report. For the reported cases, whether they are sentinel cases or whether they are serious untoward cases, for these two categories of cases, we would categorize them when they are reported. There are 9 sentinel cases or events. There are 2 types of serious untoward events. There are so many that have to be reported, but we will categorize them according to these 2 types. And then the head office of the HA and the cluster colleagues would take the next step in this regard. I wonder whether Dr. Liu has got anything to add. Chairman, the board of the HA has instructed that a panel be formed to identify improvements in the reporting system. As I explained, for the ABO blood transfusion, we can identify these cases very quickly, and within a couple of hours this can be reported. But in some cases, the patient's conditions may change, and during the course of treatment and surgery, we do need to get hold of more information before we can identify the cases. Now, for the cases that cannot be reported within 24 hours, they belong to this category. Now, it's not a case that there was non-compliance. Now, if cases are reported within 24 hours, then the head office can offer more support to the patients. There was a question as to what lesson has been learned and what improvement can be made. At the present moment, there are issues of concern to the public, and after a report has been made, we would give a press briefing, or we would give a press release for the members of the public to understand what actually happened. But for these important issues, we do have a risk alert, and the staff members would be aware of this. We do post these on our website for public knowledge. The nature of the cases, the causes, and also the areas for improvement are also included there. Now, there was a mention of the suicide of patients on home leave. Now, we do have measures proposed to improve the situation, and I can give a summary to members if it is needed. Mr. Raymond Chan, Chairman. I'd like to focus my attention on the mechanism in private hospitals. People would feel very helpless in private hospitals under the existing mechanism. It would be hard to trace responsibilities. If people want to lodge a complaint, the complaint will be lodged with the hospital, and there will be an internal investigation. They will be investigating their own kind, and the matter will be filed away. Now, I've received a report which makes me angry. Now, there was a child and parent reported it to the hospital. The hospital replied by saying that you do have high expectation of the hospital and hospital services. We cannot provide the services to you anymore. From now on, all hospitals and clinics will not make available medical care to you and your family. Now, you lodge a complaint that this is a famous private hospital in Sha-Tin. They failed to respond to you, and they told you never to turn up for any medical care, and they are shutting you out for the services. For difficult patients, you may tackle that patient alone, but they are shutting the services to the entire family. For private hospitals, shouldn't the patient file a report with the Department of Health? The hospital concerned didn't treat that as a complaint. Can you respond to this, please? Well, we're dealing with the medical incidents. Now, for the complaint to the private hospital, can you address this, please? Thanks very much, Mr. Chen, for the question. Dr. Chiu can supplement later. If there are complaints against the private hospitals, one can lodge it with the private hospital as well as the Department of Health. As Dr. Chiu said, under the existing ordinance, this is a very old piece of legislation, and there is so much that has to be improved. And therefore, we are going to put in place a piece of legislation which is more comprehensive for introduction to the floor of the Council, and this will enhance the level of service in the private hospitals, and the complaint system, the penalty and so on will be improved. Now, perhaps Dr. Chiu might wish to supplement here. Very quickly, Chairman, for complaints against private hospitals, that one can lodge a complaint against the private hospitals. One can also lodge a complaint with the DH. We don't have a lot that can be done in the way of penalty, but there is a code of practice that requires the private hospitals to formulate policies regarding patient admission and so on. If there is a complaint lodged with the DH, and if this is substantiated, then we would issue warning letters. Chairman, this is a medical blunder. The child ended up in ICU. Do they have the right to bar the whole family from the hospital? Dr. Chiu? Chairman, I'm not going to comment on individual cases. If the honourable member let us have the case, I will have a look at this after the meeting. Ms. Alice Mack. Chairman, two questions, if I may. First, in the paper, CB2, para 3, it sounds really good on paper. They have the AS system, the advanced incident reporting system, to minimize the harm to the patient and also to give support to the staff members. Are they really doing this? Now, Dr. Chen talked about the panel that is formed. Dr. Chen, that you might as well forget it. Would that minimize the harm to the patients? And also, what sort of support are you giving to the staff whenever medical blunders occur? The frontline doctors would say that they're working really flat out and they're not getting any support, and they have really a high caseload and high stress. What can be done to help them? Para 8, you are promoting reporting culture. Now, after the reporting, what next? For the patients' families and so on, what does it help with the reporting done? What help would that be for the patient's family? Now, my second question is about private hospitals. Like Mr. Raymond Chan, when we're dealing with the cases in public hospitals, you can approach the hospital authority, but the private hospitals, there is nothing much you can do about it unless you are taking them to court. Now, for the reporting of cases, some of my colleagues said that there are omissions in the private hospitals. Would there be any penalty for them? Now, I've received some cases regarding private hospitals. Now, the patients having passed away, didn't pass away in the private hospitals. After an operation, they may suffer from complications. They may be referred to the public hospitals, but they passed away in public hospitals. Will the private hospitals not be required to file a report? They will be sent to the public hospitals. Would they be absolved of any responsibility to make a report? Thank you. Thanks very much. Thanks very much, Ms. Alice Mack. I defer to Dr. Liu. I believe that the reporting mechanism for medical incidents is to foster a reporting culture. If there are any incidents that occurred, they have to be reported, and it will be good for the patients as well as the staff members, because they can learn together, they can share the experience together, and that won't make the system that much safer. Sometimes it would be a matter of the workflow, and we can certainly review the workflow and the procedures involved. Dr. Liu, I wish to supplement regarding the practices for the patients and the families.
Now, concerning medical procedures, they have become rather complicated, and so it is quite impossible for the risk to be reduced to zero. Now, what we want to achieve is that for preventable scenarios, Dr. Lau, I beg your pardon, because I've seen what happened to my colleagues, and so I have to cut in now. So you mentioned that the air system is to offer support to staff, and you already mentioned your goal of preventing something that is preventable. But what resources will be made available? Okay, so what kind of resources will be made available to support the staff? Indeed, in the course of this, some of our staff members may feel psychological pressure in facing up to the incident, and so we'll provide them with psychological support, and we provide counseling for them. And when the RCA panel has identified the findings and the causes, very often the causes may not be human errors or medical blunders. And some of the causes may have to do with medical equipment as well as manpower arrangements and so on and so forth. So when we identify the causes, when we identified the factors that are causing the event, we can immediately proceed to implementing improvement measures targeting those shortfalls. And of course, it all starts when such cases are reported to us. And so the bottom line is that such cases must be reported to us. So the awareness that such cases must be reported to us is something that is important, and that is why the hospital authority has been inculcating such awareness in the minds of the hospital management and so on and so forth. And when something untoward happens, the important thing, of course, is to rectify the cause of the event. And so we'll try our best to provide support from all angles, and we'll try to communicate with patients as soon as possible and to explain the facts to them, so that whenever necessary, a relevant mechanism can be activated. Can you give me a concrete example? Can you give me numbers and let Madam Mac know and other members know? Say, during the past few years, medical incidents have already occurred. And so if indeed the system is discovered to be not sufficient, or the medical equipment is discovered to be not sufficient, what measures have you put into place in order to rectify those? And also, for private sector hospital, Dr. Chiu, can you give me an answer? Now, there are three areas that are of concern here. First of all, omissions. Of course, we are concerned about omissions, and through various channels, we will require the hospitals to come up with their own mechanism to look into medical incidents. And so every year when we inspect these hospitals, we'll see whether they have omitted reporting cases. And another channel, of course, complaints can be made, and also the hospitals will be compiling summaries of follow-up on cases, and so that's another channel. And of the 1,400 cases that we have looked at, in 2016, we discovered that there have been 3 cases that should fall under sentinel categories. And if they fail to meet the deadline of 24 hours, or if they have omitted in the reporting cases, what we do is that, first of all, we issue warning letters to them. And when new legislation comes into place, there will be more options available to us. In really serious scenarios, we can suspend the license, or we can suspend the services. And thirdly, say our private sector refer a patient to public sector, and the patient actually dies at public hospital, then is that reportable? Indeed, that is still reportable, because after the 9+2 mechanism is being implemented, even after a patient is being transferred from a private hospital to a public hospital, and if the patient dies at the public hospital, then still that is a reportable case. And indeed, the private hospitals have done that. So after 2015, that mechanism has been put into place. We've still got 3 more speakers. Mr. Leung Kok-ho, I'd like to know whether that is to report a case or to declare a case. Because if we are talking about publishing a case, then everybody would know. But if it is only reporting a case, then they would only need to report it to their superior. So I think it is not really publishing the case. It's not letting the whole world know about the case. Now, for Madam Tang's case, it seems that it has been neither reported or published. So I just want to know whether it's publishing or reporting a case. If you are talking about declaring or publishing a case or reporting a case, the difference is that when we're talking about reporting a case, it is for individual hospitals to report the case to hospital authorities' headquarters. So it is not declaring a case or making a place or making a case known public. So this is not a publishing system, but rather a reporting system. So after a case has been reported, nobody knows how it is to be handled. They've got this mechanism that is called the release of report on SU events. So indeed, after such cases have been reported and have been handled, those cases will be published. Indeed, you can cite examples, but let's make it clear that we are not trying to go into individual cases today. Okay, so after a case has been reported, then it is up to you. It is your discretion to decide whether or not such cases will be published. So we are talking about reporting of cases, not publishing of cases. Now, about the 2016 Code of Practice for private sector hospital, it's been amended only in December 2016. Now, for this Code of Practice, it is not legally binding, is it? So they can choose not to abide by it. They can choose not to observe it. If they indeed choose not to observe it, what can you do about them? If there are no penalties, can you tell us that are you going to further amend the Code of Practice, or are you going to actually legislate to provide for actual penalties? Dr. Chiu, indeed, in accordance with present mechanism, the Code of Practice is not legally binding, and if private hospitals fail to abide by the Code of Practice, basically all we can do is to issue warning letters. But the government has already embarked on a review, and a new piece of legislation has been prepared and will be tabled very soon for scrutiny. And penalties will be beefed up. And in future, if they fail to follow the Code of Practice or fail to follow directives of health department, then we could suspend the license or suspend the services. And we could also indeed look at the performance of the hospital administrator, and if they failed to meet the requirements of the health department in a very serious manner, then we could indeed stop issuing licenses to them. So, actually, this has come under the limelight because of the United Hospitals patient case. What happened there is that the doctors and the hospital management deliberately try to hide the facts and try not to report the case. And it was actually being reported by another hospital, Queen Mary Hospital. So indeed, there is a culture within hospitals that they are trying to cover up such events as much as possible. And the paper says that 18% of the cases failed to meet the 24 deadline for reporting, and they have not been held responsible. Now, just now, the administration says that there are absolutely no penalties possible, and all they can do at present is to issue warning letters. And so it is really toothless terror on the part of the administration. And so this is a very serious problem. It seems that the private hospitals don't have to follow the 24-hour deadline at all, because there are no consequences to being late in reporting. And actually, it's not even a warning letter, it's only a reminder. So I think you are really being overly lenient towards them, and nobody is going to listen to you. And for those that have omitted in reporting cases, then what can you do? Because you wouldn't have known about those cases, and neither would the public. And so for late reports and omitted reports, what are you going to do? Are you going to have hospitals spying on one another or checking on one another to make sure that hospitals will not cover up incidents? You have to think of ways in order to optimize the system so that there'll be no more late reports and there'll be no more omission in reporting. Indeed, we're talking about reporting of cases, not publishing of cases. Okay, thank you for your question. On one hand, now for cases that have failed or exceeded the 24-hour deadline, we have to first of all look at what caused their lateness in reporting, because in some of the cases, indeed, the number of officers involved, the number of parties involved is very, very large, and information has to be collected in full before such case is or such cases are ready for reporting. And as for detailed analysis of these cases, I'm going to defer to Dr. Lau. So the question was about deliberate omission in making reports to the hospital authority, and if indeed there is medical blunder and such blunder is being deliberately covered up, there are penalties that are available to the hospital authority that could be used to slap onto the offending parties. Now for sentinel events, the bottom line is that we want to learn the lessons. We want to take something away from the incidents. So the focus is not to apportion blame. Dr. Liu, would you please not take us on a ride? He or she was asking whether there would be any good monitoring system to keep the private hospitals or keep the hospitals in line so that they would be kept on their toes and they would not be so willing to cover up events and fail to report cases. Now, every day, our headquarters will look at a summary of reported cases and reported incidents, and if there are any doubts that we feel, we immediately will check with the hospital's management. And so there are two channels. First of all, frontliners will make reports to us, and also we'll check against the list of cases that they report every day. And if we discover that there are any possibilities that certain cases actually have to do with sentinel cases or SU cases, and we would ask more questions. Now, is it possible for cross-hospital cluster mutual monitoring? The 7 clusters and the head of the 7 clusters will come together for a monthly meeting, and they would exchange notes as to whether any cases that should be flagged.
Will there be an ambassador who will be making his rounds, so that they will not be looking at their own kinds and let them off the hook? Yes, indeed, we will have a look at this. The hospital authority is conducting a review. There is a review panel that is looking at possible areas for improvement in the reporting system. Ms. Eunice Yung, para 16, refers to the fact that it would be hard to achieve 0 incidents in a complicated system. Now, they have already put in place, if they put in place an automatic prescription system, then there will not be any problems with prescription problems and causes kidney or liver failure. For para 21, the hospital authority emphasized that a lot of the problems arose from the system instead of human errors. If they are not human errors, who caused the problems? Undersecretary? Well, this is the electrical paper, para 21 of the Secretariat's paper. That's page 5. Can you cite us some examples, like the problems arose from the system instead of human errors? Yes. HA? I have lots of examples, but let me say this. There was a case in which the dosage injected was not correct, and the dosage that we sent to the ward was a concentrated dosage, and the staff had to dilute it in proportion to the weight of the babies. So one of the improvement measures is that all the drugs sent to the wards would be diluted in order to minimize the situation, minimize the errors arising from manual dilution. Ms. Young, well, that's a human problem. When injection is administered, they haven't checked whether the concentrated dosage has been administered instead of the diluted dosage. It would sometimes be hard to attribute this to the system or human error. If you shift the blame to the system, then I think that it would be rather irresponsible. Chairman, in the independent investigation panel, it would look into all the possible causes, whether it is the system or the human errors. So we would come up with the right measures to deal with the problems. But in terms of the system, if there are systemic problems, if there are problems with the measures, then the hospital authority, the cluster or the hospitals would certainly make improvements. There are 2 more members for the second round. Shall we get all the questions in? Dr. Kwok Ki and Dr. Pierre Chan. Dr. Kwok, please. Chairman, I think a fundamental question that I put is about the reporting system. The paper says 24 hours. The Undersecretary said that the investigation will not be available until July. I think we should do away with the reporting system, and in future people can choose to make a report as they wish. Now, why do you have to wait until July? The reporting system is an objective system, and you have all the procedures for reports to be filed. What difficulty would there be to prevent them from complying with the rules? You ask the hospital, how can the hospital authority and the private hospitals deal with this? Now, this is a major incident. The whole of Hong Kong is aware of this, and you completely ignore your reporting system. And you said that you have to wait until the report is available in July. Let me repeat my question. Why do you have to wait for an investigation? Why do you have to impose another condition in the reporting system of waiting for a report? Dr. Pierre Chan. Chairman, in my second round, I think we have to be lenient if they are honest, and the hospital authority said that the staff have to file reports. The Department of Health doesn't have any power to mete out any penalty for non-compliance. And for schools and correctional services department, they don't have any reporting system. Now, the hospital authority is pretty transparent, but they are on the receiving end of a lot of criticisms. Now, 20% fail to comply with the 24-hour deadline. In Appendix 2, there are 9 items. Can you tell us more specifically what caused the delay in filing a report? Like pregnant women in labor and so on. I mean, are there specific circumstances that would cause a delay in filing a report? Undersecretary, thanks very much, Dr. Kwok and Dr. Chan. Now, on Dr. Kwok's question, it's not the case that we have to await an investigation first before filing a report. Now, there are 82% of the cases that complied with the 24-hour reporting time. In other words, 18% of the cases went beyond the 24 hours. There must be their own reasons. I cited some of the possible reasons. Of course, the HA would pay attention to this and identify the reasons why. Now, for non-compliance, there ought to be some penalty system. I mentioned the independent review panel. I'm not linking this with the reporting system, so I think I have to make a clarification here. Regarding Dr. Chen's question, Appendix 2, defer to Dr. Liu. What are the items that are likely to cause a delay in reporting beyond 24 hours? Now, for item 2, retained instruments after surgery, some of them are pretty obvious, and some of them are easy to identify as a result of the surgery, but for other cases it would take a day or two for data to be collected. Now, the other thing is medication error resulting in permanent loss of function or death. Now, sometimes we have to ascertain whether there are complications arising from the medication or the death, whether the death was caused by the medication. Now, we have to ascertain the causes. And sometimes it would take us more than 24 hours. Item 9, other adverse events resulting in permanent loss of function or death, excluding complications. In the medical procedures, there are certain situations where we have to work out the possibility or the probability, and there is a need to have some communications to be made. The medical staff would like to get on with the medical procedures, and the non-compliance with the 12-hour will not cause any particular problems. I think we have spent enough time on this. There are questions that were addressed. There were questions that were not addressed. Under Secretary, you might wish to have a look. There are some statistics that members are interested in. Now, whether it is a reporting system or notification system, indeed, the frontline staff should be given as much support as possible. Right, that's it for this item. And let's move on to the next item. Welcome the Secretary. I think this is the last time the Secretary is attending our meeting, barring for unforeseen circumstances. Now, this item is strategic review on healthcare manpower, planning and professional development. Perhaps we can extend the meeting by 15 minutes. We'll end the meeting at 6:45. Secretary, please. Chairman, thanks very much, and members for their support of the Bureau's work over the years. The report is rather lengthy, and I assume that members have already read the paper and the report. Perhaps I can go straight to the questioning. Myself and my colleagues would be only delighted to take members' questions. All right, I have 6 members, Dr. Kwok Ki, Dr. Elizabeth Kwok, Mr. Siu Ka-chun, Dr. Helena Wong, Mr. Raymond Chan, Dr. Pierre Chan, and Mr. Lang Kwa-hong. 3 minutes each, please. Dr. Kwok, Chairman, I welcome this manpower planning review. We have been awaiting this for a long time. Chairman, if our memory serves us right, what I'm concerned about is the shortage of doctors. We understand that the shortage of doctors stemmed from 2003 when the administration failed to hire the medical graduates for financial reasons. and the number of medical graduates have not been increased. The number has been reduced, if anything. Now we have seen an increase, and in 2 years' time we're going to be seeing more graduates from the medical school. My question for the administration is this: for these graduates, there are more than 460 of them. If the wastage rate is not as high as this, when the economy is not good, the wastage rate will be reduced, and the government doesn't have the resources. Does the government have any undertaking regarding the number of doctors that will be trained up for them to be qualified medical practitioners? Now these graduates have to be hired in full. If we repeat what happened in old days, it would be irresponsible. Now there are many hospitals that suffer from a shortfall of doctors. Not only has the government not retained the retiring doctors, Dr. Koh must be aware of this. In QE Hospital, some of the retirees were not retained because of financial problems. That the government is running short of doctors, and there are experienced doctors that fading out through retirement, and their contracts have been reduced after retirement from 3 years to 2 to 1, and they have no option but to go into private practice. If you want to know about the names, I can make them available after the meeting to Dr. Kuo. This is a waste of talents. How are you going to respond to this?
Indeed, around a decade ago, that situation has occurred. But if my memory serves, subsequently, in terms of policy, the government has already made a declaration that all new graduates would best be placed in public hospitals until they have matured to a certain point. And such a declaration still is valid. So it will go on. And if you've got information pertaining to your case, I would like to follow up on that, because I'm a little surprised to hear that when manpower shortage is so serious, a retiring doctor is let go. It's a surgery department of Queen Elizabeth Hospital. And if indeed such a case occurred, as you described, then the hospital management owes an explanation to the government. So if that indeed has occurred, you are not going to allow that to go on without any consequences, right? Yes, indeed. Now, for the medical graduates that have already gone through the 7-year program, they're already licensed. And these graduates could choose to go into a private practice. However, if they want to go into training, then they have to go through the hospital authority system. Okay, thank you, Chairman, for correcting me. So it's not like that after they have gone through medical school for 7 years, they still haven't got a license and cannot practice. The graduates of medical school are actually fully licensable medical practitioner, but of course they could choose to go into the hospital authority system and then to get a license or sit for the licentiate examination for becoming a specialist doctor. And so please do not misunderstand. Once you have gone through 7 years of medical school program and have graduated from it, then you are already licensed to be a doctor. But if you want to go on to become a specialist doctor, then you have to go into the hospital authority system for further training. Indeed, you're right. I hope that a public hearing can be called as soon as possible. Because having heard the dialogue between you and the Bureau Secretary, I really have to step in and try to clarify it. So please don't misguide or mislead the public. Once you have gone through the medical school and graduated from you already can practice as a doctor. Indeed, we've been waiting for this report for a very, very long time. We've been craning our necks for this. But it seems that it still places too much emphasis on quality rather than quantity, and still it doesn't address the problem of insufficient doctors and too many hospital beds. And members of the public have already felt the shortfall of doctors. At present, doctors are not spending sufficient time on individual patients, and the nurses are all overworked. And so the present establishment really is lacking in sufficiency. And of course, the best way is to increase the number of nurses, number of medical professionals, and number of doctors, but there are no short-term solutions for that. And so, in the near term, how the government can improve medical services quality when the number of medical staff would remain more or less the same. At present, there are many voices saying that the government should project future manpower demand on the basis of or against the background of a certain minimal level of quality of service. And of course, possible options have been floated is to get non-local doctors and medical professionals to come in to the stream. But at present, there is a lot of obstacles in the path of getting non-local doctors registered. And so what are your plans on this? Of course, local doctors associations are saying that foreign doctors should not be allowed to come into Hong Kong to work because there is no assurance of quality. And so how can the government negotiate this obstacle? How can you make sure that foreign doctors can come into Hong Kong to practice and at the same time service quality will not be compromised? I thank Madam Kwok for her question. In the long run, you have already seen the report, and many of the medical professions are in phase of rather serious shortfall in manpower, at least in the mid-term. And indeed, we have heard views saying that we shouldn't only look at present quality and quantity. And whenever we do manpower demand projection, we have to make assumption on the basis of present level of demand. But that is only to act as a point of reference, to aid our projection into the future. Indeed, if we want to improve quality and quantity in the future, so that medical professionals, including doctors, would be able to spend more time with an individual patient, definitely that would create more manpower demand, and manpower shortfall would become more serious. Now, this is the first time in history that such a strategic review is being undertaken. And indeed, we have made use of the present benchmark so that we know at least against the backdrop of using the present manpower demand level, what is the present shortfall. So at least we have a basic idea as to what the present shortfall it is, so that we can use that to project what future shortfall is going to be. In the long run, if we want to make planning and if we want to make resources available for it, we have to take into account a lot of variables. And so we have to do another review as time goes by, and actually on a regular basis from now on, maybe 3 years down the road. And so, against the backdrop of improving quality and quantity, how much more the shortfall is going to be? Indeed, the shortfall in number of doctors is rather large, and that's something we have to face up to. And it seems that most of the shortfall actually is within the public sector, and in the private sector there is more flexibility. And indeed, this is an observation by some of the doctors within our community. And how to top that up, our attitude is very clear. The best option to meet present medical service demand is to rely on locally trained medical professionals. And that is why our bulk of our measures is to adjust the enrollment of local medical schools. Now, because there is certain lead time that is required before a medical trainee can graduate from medical school, so even if we were to increase the size of enrollment today, the fruits will not be reaped until a number of years later. So what can we do in the interim to engage freelancers or part-timers, or to retain retirees, and for existing staff to work a little bit more on special allowance, and to retain talents and retain manpower at all levels? Now, these are the interim measures, and so I'm going to ask the hospital authority to look into ways as to how best to retain manpower and talents. Now, on top of those, there is also the added option of bringing in non-local medical professionals. Now, for admitting such professionals into Hong Kong, we have to allow for sufficient level of flexibility so that we can bring them in at the same time, but in the long run, it would not affect the overall manpower supplied over a long period of time. And that's why we are floating the idea of a registered doctor on a limited basis, i.e. these doctors can be registered to be working at public hospital, but they will be subject to a certain period of validity, and beyond the period of validity, they will not be able to automatically get re-registered and work in the private sector. So we hope that through such a limited system or restricted system, we will allow sufficient flexibility for bringing manpower, and at the same time will not affect overall manpower picture in the long term. Indeed, it's been said that we've been craning our necks for this report, but I'm from the welfare sector, and I actually am very, very envious, because it seems that no similar strategic review has been done for the welfare sector. Anyway, I've got several questions concerning the 2015 benchmark. The hospital authority study says that 80% of the consultations have been less than 10 minutes, and 1/3 less than 5 minutes. And so it goes to show that doctor shortfall is very serious. And the report is using 2015 as a benchmark, and it assumes that 2015 will see a break-even between demand and supply, and you are making projection all the way into 2023. I beg your pardon, 2030. And so what is obvious that in 2015, the manpower situation is already lacking, is already suffering from a shortfall. And so how can you use it as a benchmark to make projection for 2030? Wouldn't it widen even more the shortfall? And also, for psychiatric nurse category, it is said by the report that the supply is sufficient. However, in another report, it is said that each psychiatric nurse is now handling 50 cases, and you say that that is not satisfactory, and that the number of cases handled should be lowered to 40. And here, this report says that the number of psychiatric nurse is sufficient. And so isn't there any conflict between the two observations? And thirdly, I think with regard to doctors' problem, it is not really an insufficiency in numbers, but because of uneven distribution of manpower. Because many doctors and many midwives have migrated from public sector to private sector, and so it seems that there is an uneven distribution of manpower. And so no matter how many years you invested in training up these people, it seems that you are merely training up talents for the private sector. And once these people have completed training, they would immediately move on and jump ship to the private sector. And the public sector will still suffer from a chronic shortage of manpower. And it seems that this report has not addressed it. So 3 questions. The assumption that is based on a 2015 benchmark. Now, whenever you do an assessment, you have to use a certain specific baseline. We are not saying that we accept that what's happening in 2015 is already acceptable. We are merely using 2015's scenario as a baseline. To use 2015 as a baseline would enable us to calculate our numbers in the way that is described. And then we would then be in a position to project, if we are to maintain the present quality and quantity, what would be the shortfall in 2013? And if we want to improve the quality and quantity, what would then be the alternative shortfall for 2030? And so I won't be worried that simply because we use 2015 as a benchmark, we would be misled into thinking that manpower supply is already sufficient and would then become complacent. That's not going to happen. Secondly, about psychiatric nurses, the example that you quote actually can really describe the problem very nicely. So first of all, we have to assume what is the manpower demand based on the present level of service. Now, at present, case managers' number is insufficient, and also manager to patient ratio is insufficient, and this is something we acknowledge. And the report says that, relatively speaking, supply of psychiatric nurses is more abundant. But it doesn't mean that we are not going to do anything. It doesn't mean that number of psychiatric nurses is already fully sufficient. Actually, on the contrary, it would actually give us more motivation to press the hospital authority to engage and hire more case managers in order to bring caseworker and patient ratio down to a satisfactory level. Now, as for manpower shortfall, is it because of actual number that is being lacked, or whether it's because of an uneven distribution of manpower?
We have a dual system in Hong Kong. We cannot require, we cannot prevent or stop doctors in public hospitals moving to the private sector. So we will make sure that there will not be too many doctors gravitating towards the private hospitals, and one of the ways is to make sure that we have a dual system. So in this term of administration, we saw that there is one thing that should be rectified. Now, there were 4 plots of land from the previous administration designated for private hospitals, and we spotted the problem. Now, we are suffering from a lack of capacity. We're running short of people, and therefore we revised the direction a little bit, and we told the community that in terms of the quality of staff, in terms of the integrity of medical staff, we should be able to develop the medical sector and provide a high quality of medical services to Hong Kong and in the neighboring region. But we don't have the right condition because of the constraints in our facilities and in our capacity. So for the 4 plots of land designated for private hospitals, we scaled them back, and we tread it carefully. On the one hand, we do need to have an expansion in the private sector capacity so that the public hospitals can divert some of the patients to the private sector. But if the private sector capacity is expanding rapidly, then there would be implications on the manpower situation in the public sector. So we strike a balance very carefully. well, for psychiatric nurses, secretary, there are some clusters that said that they run out of money to hire the psychiatric nurses. Would there be any surplus in nurses in this category? All right, Dr. Helena Wong. Chairman, I am glad to see this report, although there are details that have to be further discussed. I go along with the idea of having a public hearing. First of all, in the paper, there is a mention of the Hong Kong U generic manpower forecasting model. Now, basically, you adopted this model to project into the future. In footnote 1, you mentioned the factors that you had regard to. In this model, have you considered the performance pledge of the government? For instance, for the specialist waiting time, it should be reduced to no more than a certain number of months. Do you have any performance pledge built into it for you to project into the future? Second, the paper also mentions paragraphs 8 and 9. You from doctors through to nurses and the allied healthcare professionals, there is a need to increase them, and you like to train them locally. You have to rely very much on the UGC-funded institutions. You have medical schools in Hong Kong U and CHK, and Poly U is producing a lot of nurses. In the long term and medium term, you need to have more places of UGC-funded institutions, but the first-year, first-degree places has been capped at 15,000 per annum, according to the UGC. Now, we have been criticizing this for a long time. If you want to increase the number of places for medical school, or nursing places or physiotherapy at the Poly U, if there is a cap on the total number, the only thing that they can do would be to do top slicing. They cut back on certain disciplines in order to increase the number of optometrists, nurses, and doctors' places. That would get us into trouble. Of course, I would like to increase the number, but you have to cut back on one area in order to make up for the other areas, and that is not a good idea. I hope that you would talk with the Education Bureau. Can they increase the number from 15,000, and the increase in the number will not compromise the 15,000 per annum. Now, if you snatch the places away from social science, and the school will be suffering in the mathematics faculty or astronomy and history and so on, they will suffer. Dr. Koh? Now, for the service target, we do have the performance pledge. The hospital authority has to look at the clusters and the performances of the different clusters. Now, we will look at the performance pledges, and they would include the waiting time and so on. We'll have to look at the performance target, although we don't have the performance pledges. Given the insufficient resources and the rapid expansion of the services, that they do have a target for A&E department. For the other disciplines, we don't have any rigid targets, because if we formulate these rigid targets and we don't have the conditions to achieve them, then the front line would be suffering from the sharp end of it. Please do not converse between you. So we don't have any rigid targets. Our manpower assessment is on the basis of the existing services. Given the existing services, we project the demand into the future. Now, for the existing services, of course, there are certain criticisms like the long waiting time and the limited time that you spend with the doctors. Now, we'll have to look at these as part of our improvement measures. And we look at the current situation, and if there is a shortage of manpower, we will increase the manpower. That's the basis on which we look at the issues. As regards the degree places, I appreciate your comments, but you must understand that it will not be driven by the Health and Food Bureau. The Education Bureau would have their own rationale regarding the number of university places, not for the HFB to dominate the policy. If we can seek more resources from the UGC to increase the number of places, it would be good, but otherwise we would accept a situation where some of the places would have to be self-financed, and through the governing system, if they measure up to the standard, then we will seek resources to subsidize these kind of places. That's the current practice. It's not a question of us not being happy with the number of university places. Of course, the education policy should not be driven by the Food and Health Bureau. Mr. Raymond Chan, Chairman, we said that the medical services are not adequate. Medical, dental, they're not adequate. I asked the administration whether they don't have the manpower, whether they don't have the resources. Now, from this report, we know that there is a number, and we will try to catch up with the numbers. In particular, the shortfall of doctors. The public hospital is the worst hit area. Now, there would be more flexibility there. In Appendix C, it mentions the public sector. There are only 2 points. One is to extend the retirement period and to recruit those who have already retired. I'm not sure how much this would be of assistance. The other thing is to hire non-local doctors through a limited registration. This can be discussed at a medical council. It seems that the world over, we're suffering from a dearth of doctors. Now, by extending the period from 1 year to 3 years, would that be sufficiently attractive? Now, the report doesn't mention whether we're losing out to other countries in terms of working environment, the pay and conditions, and so on. In the public sector, the doctors are working under tremendous pressure. They have a high caseload. The working hours are exceedingly long. If you pay them more, you may not be able to stop them gravitating towards the private sector. So has the administration considered the competition and the conditions and so on? Are you going to increase the doctors' pay substantially for the public sector? Have you ever considered this? Dr. Koh? Well, Mr. Chan, you said that we only have these 2 measures. I hope that you would read the report in its entirety. As I said at the very beginning, anywhere in the world, including Hong Kong, it is their policy to train up the resources locally to meet the demand. So we're not just limited to the 2 measures you mentioned. If you train up local doctors, it would take time. The points that you mentioned are really short-term palliative measures. And anywhere in the world, they would consider all these palliative measures like to extend the retirement period and also to hire the retired doctors, or we can offer special allowance to attract existing staff to help out. There are different measures in different jurisdictions, and in these places, as a short-term measure, they would hire non-local doctors. Now, what you said is also important. As I said in response to one of the other members, all these measures aside, it is high time we looked at the retention measures. We've already started looking at this with the hospital authority, and this will include the examples that you cited, like the paying conditions that we offer. These are early days yet. I cannot come up with any specific measures yet, but I get a feeling that it is time for us to look at the retention measures. In between them, it doesn't mean that the HA hasn't carried out any of these measures. A couple of years ago, the HA did improve the promotion prospects of the specialist doctors. But I do feel that this is high time we had to look at the retention measures. Dr. Pierre Chan. Right, I think he's going round and round in circle. Let me answer the question. The hospital authority cannot give the doctors a raise to retain people because their pay cannot be more favorable than the counterparts in the civil service. The only thing they can do is to retain people through morale boosters. Dr. Helena Wong talked about the recurring expenditure and the places of UGC that they have to cut back on other areas before they can achieve any increase. My question is this: that the CUHK Hong Kong, you have been commissioned to conduct the study. How much did it cost the government?
提供到而家提供，如果提供唔到嘅時候提供。
有冇數字俾到？
好，主席呢個資訊性嘅問題，我哋會後提供。
唔緊要，第一好，我知道實冇噶啦。第二就係近呢5年呢，其實2間大學嘅醫學院共喺個教資會度可以獲得幾多嘅資助？2間大學嘅醫學院。似乎又係一個資訊性嘅問題。
陳議員，如果你一評嗰啲數字，你問實。
Once again, another point about information. I just don't want you to feel let down, and so why don't you exhaust all your questions first? Now, if we're talking about information that members would like to get, then maybe we can give the information in writing. Now, in 1999, Harvard University actually has done a projection concerning the money as well as manpower that will be required for 2016, and their findings have all fallen very far by the wayside. All of them have been missed. And if this particular report is to be tendered as part of a PhD dissertation, then it definitely would flunk the test. Because here it does not describe the methodology, does not describe any formula. And concerning definitions for manpower, or performance pledges as mentioned by Madam Wong, those have been missing in the report. And so you can simply not find the ways and the basis on which you make your projections. Now, if the government has commissioned an academic institute to do this report, and the 2 universities actually stand to gain by increasing the number of teaching staff, and they stand to gain by getting more resources, and yet they come up with such a report, then this is something that is simply not acceptable. And so, can you let us know the formula of calculation for making the projection? If you're talking about methodology, the electrical panel of the last term actually has already had a very lengthy discussion on this, and they've got a financing subcommittee, a medical financing subcommittee, to look into this issue. I do not have any other comments on the members' remarks. Mr. Chen, you mentioned that hospital authority staff is pegged to civil service staff's pay. Now, if memory serves, the guiding principle is that the pay and the compensation for hospital authority staff should not be worse off than civil service staff, but it doesn't forbid hospital authority staff to receive a higher pay or better pay than civil service staff, because the two staff scale is already delinked. So I want to ask a question that if we are to use 2015 as a benchmark, and the present level of service is already falling short, and you have to recruit more people, you have to retain more people, then are you going to increase the pay for hospital authority staff? I'm not going to answer on behalf of the administration. Now, when civil servants get a pay rise, then because of expectation management, then hospital authority is very likely to follow suit. Now, if there is a gap in terms of compensation between hospital authorities, doctors, and private sector doctors, are you going to increase the compensation package for hospital authority doctors so that they will not have any motivation of jumping ship and being poached by private sector? For doctors working in public sector, now if I'm wrong, Mr. Chen can correct me. What is clear is that in the private market, a doctor faces a whole different set of rules of game. If we are talking about a specialist doctor, indeed, he may do better in terms of compensation than he would be in the public sector, but we do not have any formal survey to ascertain how big the shortfall is or how big the gap is. I just want to know who is poaching whose doctors. Is the private sector poaching doctors away from public sector, or is it the other way around? Now, if there is a certain gap or difference between pay packages of hospital authority doctors and private sector doctors, then you have to do something to address that, because you simply cannot allow an exodus of doctors from public sector. Now, most of medical graduates would join public sector hospitals to receive training, and after a certain number of years, then these doctors would have to make a choice. And at what point in a career would they make such a choice? It differs from one person to another. Certain doctors would decide to stay on in the public sector till retirement. But there are other doctors who feel that they have already done and seen, or they can do and see in public sector, and so they migrate to private sector. And that's why most of the migration will be from public sector to private sector in terms of doctors, and it is much rarer the other way around. Not because of the difference in pay packages, it's all because most of the graduates would first join the public sector before moving on to private sector. Okay, so that's a logical relationship, because the first stop for medical graduates will be public sector hospital. Now, if the wastage rate or the poached rate of private doctors or of public sector doctors remain the same over the past 10 years, then your logical relation can be valid. The hospital authority monitors its manpower level very closely on a regular basis, and every month when I have meetings with them, they have very detailed record on the wastage rate for major categories of medical staff. And during the past few years, the number has remained stable at 45%. Of course, there was a time when the wastage rate was as high as double-digit, and in those particular years, the doctors were lost not only to private sector but also to overseas countries. But in recent years, the wastage rate is around 4 to 5%. Now, if you compare the compensation package between public sector hospitals and private sector hospitals, you have to realize that the public sector doctors are subject to a monthly salary system, whereas a private sector hospital will be subject to a commission and bonus system. Now, concerning the methodology for survey for this strategic review, I recall that during the last LETCO term, I also joined the relevant medical financing committee looking into this issue. Now, back then, we were already told that it was already projected that after a certain number of years, there will be a shortfall of doctors. I don't think anybody would agree that we already have sufficient doctors within the hospital authority system, and we do not agree that at present there is already too many doctors. I think we all agree that there should be a better supply of manpower so that doctors' workload within the public sector would be lessened and patients ultimately would get better care. Just now, the Bureau Secretary as well as several of our colleagues have already received a letter of petition from a group of elderly people, and they are calling for shortening of waiting time for patients and increased level and improvement to level of service. So everybody supports an increased provision of resources and increased supply of manpower. And yet, after everybody agrees that there should be an improvement on this front, there are queries as well as questions saying that the methodology for this survey and for this review is not accurate, and that private sector statistics are not comprehensive, and that's why the findings are not accurate, and so on and so forth. And so, Bureau Secretary, can you let us know that indeed you are going to use this report to fight for more resources from the central government or from the SAR government, so that resources can be made more abundantly available, so that the level of manpower can indeed be increased and the level of service can indeed be improved? First of all, the government has taken the initiative to run this manpower strategic review for the medical sector, and it's been pointed out that this report that is being produced by the universities, commissioned by us, actually is scientific as well as comprehensive. But the report, as any other report, is based, or these findings report, as is findings in any other report, are being based on certain assumptions. And we have to face up to the fact that there must be assumptions that are being used for the production of this report. And when the report findings say that there are shortfall, then we have to face up to it and we have to address it. And what we can do is to fight for more resources within the government. Say, if we want to increase the number of doctors by 50, it is way more complex than simply creating 50 additional places. We have to first of all increase the provision of resources before we can proceed to increase the number of doctors. And in future, if necessary, I can speak on behalf of my bureau that we will definitely ask for more resources from the relevant bureau. It's only that at this point in time, or during the past few years, we've been having a hard time fighting for resources, in the sense that even if we're able to secure the resources that we ask for, we are not able to recruit the needed talent. But as we move on, in future years, when the supply of manpower is made more abundant, then when the resources are already available, then we can have a much better time and easier time in recruiting the talents. Mr. Zhang, of course, planning for medical manpower is very, very important. Having gone through the report, I have to tell you that I'm very, very let down. I have the feeling that Mr. Cole is really dodging the issue. Whether or not medical personnel is in sufficient supply really has to do with life and limb of our citizens and also long-term quality and level of service. The Bureau Secretary said that the manpower projection was being based on 2015 benchmark. And for Kowloon East cluster, for the osteopathic specialty, the waiting time was 3 years. And in other clusters, it's also close to 3 years. And the waiting time in many of the specialties, waiting list is really very close to being unacceptable. And in 2015, that was also the year in which the Cambridge Home for the Elderly was found guilty of abusing their elderly inmates. And 2015 also was the year when projection for dentists and doctors manpower was being produced, and the projection was that there was only a shortfall of 360 doctors and 150 nurses. So that's the 2015 benchmark, but that is already horrendous. We are one of the places where the ratio between dentists as well as nurses to size of the population is the lowest. And by 2013, it is projected that we are going to have a shortfall of several thousand doctors and nurses. And at the same time, in the same breath, you say that the UGC funded programs cannot be altered in too great a manner. And that's why you have to rely on self-financing courses. At the same time, I also hear that the Bureau Secretary has no authority over the UGC institutes in order to increase the number of subsidized places.
We've increased from 320 to 400 odd medical student places. Now we know full well that there will be disastrous shortfall, and the Secretary here is telling us that he cannot influence the number of people being trained up. Why are you enjoying such limited power? We are subsidizing these places to train up the doctors that are very much in demand. And you tell, will you leave some time for the Secretary? We've got 7 minutes left. I have to address this question. I raised my hand. Dr. Zhang, I think you are really one-sided. I didn't say that I couldn't influence anything. I made it very clear that the Bureau, my Bureau, cannot drive the education policy, although we would try to fight for more resources. If you can fight for more resources, all well and good. Failing that, we would still resort to the self-financing means to subsidize the undergraduates. We try to proceed in both ways. Now you said that we're not really taking this sufficiently seriously. In 2015, we didn't pick this year. In particular, it's just that in 2015 we gathered the information. We announced the details in 2017. The work has been going on for 2 or 3 years. When we gathered the data, we used that as the basis. I said many times that we're not saying that the basis for that year or what we are producing is is satisfactory. We have to start somewhere. Even with this quality, we may not be happy with it, and we have to work out how much we are short of, and then we decide how much we should increase the level of service by, and that's the yardstick that we use. When we produce this report, we have to face up to this issue of seeking more resources, creating more places. If we can get the resources from the UGC, all well and good. Otherwise, we will try to get the resources to meet the demand. Mr. Chen Kin-po, Chairman, before July 1st, I think we're going to have a more meeting of the panel, and I think I have to praise the Secretary. The healthcare sector is such a massive sector with so many interests at stake. I think the Secretary has been doing all the impossible tasks to improve the situation. And I really like to show my gratitude to the Secretary for working so hard for Hong Kong. I hope that you would come back in the new term. I know that you would like to be a clinician again, but I hope that I can be your patient if you go into private practice again, because I have full faith in you. My grateful thanks to you, Secretary. Now, my question is this. Of course, we're glad to have this strategic review on healthcare planning, manpower planning. After the review, the government has to do something about the situation. Of course, one of the means is to increase the number of places. I think the most immediate solution is to bring in doctors from outside Hong Kong. What are the major difficulties encountered by the administration in bringing in doctors? Second, I heard from some doctors that if you hire doctors on a part-time basis, or if you hire retirees, the conditions are not sufficiently attractive. So what can you do to improve the situation in this regard? Third, there are some concerns that when the economy is hitting a downturn, the government will be reducing the number of doctors being hired. How would you address these? Thanks very much, Mr. Chen, for the three questions. First, to the importation of non-locally trained doctors. I said before, and I say again, that in any jurisdictions they would focus their attention on the locally trained talents, unless they don't have the scale to achieve that. But I mean, we do have the scale in Hong Kong. We would focus our attention on locally trained doctors to meet the demand that is very much the backbone of our service. But we do need to have some emergency measures, because the training would follow a cycle. So we would like to have some flexibility to bring in non-locally trained doctors. And this is the limited registration system that we have adopted in Hong Kong. The beauty of the system is if they are hired by the hospital authority, they will only be working for the hospital authority, and they cannot become local doctors without an examination. They cannot practice in the private sector. The mechanism has a drawback, and that is they have to be subject to vetting every single year. And if they have only 1 year in the registration, it would be hard for them to have any career plan, so many cannot be bothered. So in the medical registration amendment bill, we are addressing this specific issue. Second, for part-time doctors and the paying conditions, I've heard the problem many times. Basically, the pay and conditions, if you work it out on the basis of hourly pay, it would not be comparable to the doctors working for the hospital authority. But the HA has explained on more than one occasion that it has to do with the the on-call duties. If these part-time doctors are prepared to serve on-call duties, then the hourly rate will work out about the same as full-time doctors. The nature of part-time doctors means that some of the doctors are not prepared to work on call, and it would seem, deducting this, that the pay, there is a discrepancy in pay. So we make sure that there has to be fairness in the system. Economic downturn, will there be less doctors? Can we hire all the doctors? Some years ago, we have stated our policy that after 5 years and now 6 years of training, and after internship, and after they have been registered with the medical council, they have the liberty to practice anywhere they like. But as part of our policy, we feel that we should provide a channel to hire all the medical graduates in Hong Kong, so that prior to their registration, they would be able to receive further training at the hospital authority before they move into the private sector for private practice. Now, in the public hospitals, we work as a team, but in the private sector, they can be working as an individual doctor. So policy-wise, as long as they are prepared to be hired by the hospital authority or the DH, we should hire them all. Right? I don't think we'll be able to exhaust our discussion on this subject. There is a suggestion of public hearing, and we are going to have a public hearing to receive deputations from the patients groups and all the concerned groups, and arrangement is being made. I think we have to bring it to a close. My thanks to the Secretary for working with us all these years. Once again, Chairman, my thanks to Chairman and all the members for supporting the Bureau's work over the years. Thank you very much. Right? All the best. Thanks very much. We don't have any AOB items. Meeting is adjourned. Thank you all very much.